tonight.
I went for the colonoscopy. That's when I learned that I had a very large tumor.
Unfortunately, she was found to have a rectal cancer.
An ABC 27 special presentation.
My daughter and I sat in the car and just looked at each other like, did that just happen?
Colorectal cancer, a matter of fact. Sponsored by Penn State Health, Milton S. Hershey Medical Center.
Good evening, I'm Deborah Pinkerton. March is National Colorectal Cancer Awareness Month. Colorectal cancer is the third most common cancer in the United States for both men and women, and it's the second most common cause of death from cancer overall. In the United States, there are about 150,000 people diagnosed with colorectal cancer each year. Is colorectal cancer genetic? Why is it important to get screened? And when should you have your very first colonoscopy? Well, tonight you will find out. And if you have any questions at home, Amanda Peterson is here to tell you how to get them answered. Amanda?
Thank you, Deborah. Specialists from Penn State Health are in the ABC 27 call center to answer your questions until 8 o'clock tonight. Just call the number at the bottom of your screen there or email your questions during the show to questions@abc27.com. Nurse practitioner Christine Ardell will answer your emails throughout tonight's show. All calls and emails are confidential. And I'll be back later in the show to share some of those questions with you. For now, we send things back to you, Deborah.
Thanks, Amanda. A Lebanon County woman had a family history of colon cancer. Doctors advised her to get screened at a young age. Here's Jamie Ham's journey.
Morning, King. Hi, buddy. Hi, buddy.
Every morning at the crack of dawn, Jamie and Jennifer Ham come to the barn to take care of their horses.
Yeah, we'll get you some hay, we'll get you some fresh water. You'll be good to go.
These horses kept Jamie going through some of the toughest days of her life. It began 3 years ago when Jamie was scheduled for a colonoscopy.
I was very sick. I was very tired. Even prepping for it was like childbirth, and I knew something was wrong.
She couldn't go to the bathroom. She was just really in pain, and it wasn't like her normal colonoscopies where it was just the process and it was fine.
Jamie had a lot of experience prepping for a colonoscopy. She started having them in her early 30s because of her family history.
My grandfather, William, he died in his early 40s of colon cancer. My mother developed cervical cancer when she was, I'd say, in her 30s. A few years later, my mother was diagnosed with colon cancer. And then about 10 years after that, my mother was diagnosed with breast cancer.
Doctors urged Jamie to have a colonoscopy every 5 years.
My first reaction was, wow, I'm this young and I have to start going through this. And of course, it's not going to happen to me was my first thought. I'm young, it's not going to happen to me.
The results of the colonoscopies were fine until 2013.
After the procedure, he said to me, there is a tumor. It was so large, I could barely get the scope in to even look around. From my naked eye, I can tell you that it is cancer. We'll wait to hear from pathology.
Pathology confirmed it was rectal cancer.
What was your reaction? There was none.
There wasn't none. I was, my daughter and I sat in the car and just looked at each other like, did that just happen? And I think we sat there for a good, at least 10 minutes just looking at each other because you're just numb.
I was kind of taken back by it because I thought that doesn't happen to you. I thought my grandmother having it happen was a fluke thing, and I remembered her being very sick, but I never thought that would happen to my mom.
Jamie scheduled an appointment with colon and rectal surgeon Dr. David Stewart.
This is a representative photograph of the colonoscopy that diagnosed Jamie's rectal cancer. Here what you see is normal mucosa. This is what the lining of the colon or rectum should look like. But this is quite abnormal. And this is a very characteristic appearance of what a colon or rectal cancer would look like at a colonoscopy.
Dr. Stewart was suspicious Jamie's rectal cancer was genetic due to her family history.
Before surgery, I was very concerned that Jamie probably had Lynch syndrome. A person with Lynch syndrome has certain changes to certain genes that are responsible for correcting errors in DNA. And when those genes don't perform their function, more and more errors can accumulate. And as a result, colorectal cancer and other types of cancers are far more common in Lynch patients than they are in patients without that problem. Unfortunately, although I requested genetic testing, there were some barriers to obtaining that before surgery, much of which went to her insurance carrier authorizing that testing.
So 16 days after Jamie's rectal cancer diagnosis, Dr. Stewart performed surgery.
So when they did take me into the operating room, I was actually excited and happy. I was looking forward to it because, in my opinion, this was the end.
When they wheel your mom away, you think, am I going to see her again?
The procedure that I performed was called a single-site laparoscopic low anterior resection of the rectum. And what that involved was making a single incision in Jamie's abdomen and basically laparoscopically removing that part of her rectum that harbored the cancer, but making sure that we removed enough normal tissue that would give her the greatest chance of curing her cancer.
We sat all day in the waiting room waiting to hear something. And then Dr. Stewart called down on the phone and he's like, it went good, everything's fine.
The pathology demonstrated that Jamie had a stage 3 proximal rectal cancer. And those sorts of cancers, because there are lymph nodes involved, will benefit from chemotherapy after surgery.
Dr. Stewart had removed an awful lot of lymph nodes. He assured me that he did, a thorough job, that my next step would be chemo.
Jamie went through 6 months of chemotherapy.
After the chemo was done, I went for my body scan. And that was probably the second most scary day. The first day was finding out I had the cancer, and then the body scan, because that was to determine really if everything I went through worked.
We confirmed that there was no evidence of any disease recurrence outside the rectum. Jamie had a repeat proctoscopic examination as well as a colonoscopy, and that revealed that there was no evidence of a recurrence of her rectal cancer or any new polyps or cancers anywhere else in her colon or rectum.
Almost the same day, I learned that I was cancer-free. I went to work. I came home and my daughter had a cake and presents for me. And her and I celebrated being cancer-free.
Great news, but at the same time, Jamie was still very concerned.
Once obstacles provided by insurance authorization were removed, Jamie underwent genetic testing.
I was tested for the genetic gene, and I did test positive. I do have Lynch syndrome. In the back of my mind was, oh crap, my kid, my daughter. What have I done?
Her oncologist said, you need to test your daughter. And I didn't want to get it done because I didn't want to know.
And I said, it's very important that we need to stay ahead of this. And if I did pass the gene on to you, we need to know.
As you can imagine, it was a very difficult time for Jamie and Jennifer. Coming up, you will find out if Jennifer was tested for Lynch syndrome. Joining us, colorectal surgeons Dr. David Stewart and Dr. Fran Pulio. Thanks for being here tonight. Jamie never suspected she had colorectal cancer. Is this fairly common?
Unfortunately, Deborah, colorectal cancer is very common, and as you shared earlier in the show, it's actually the second leading cause of cancer death in both men and women in our country, so it's a significant public health concern.
Is surgery always needed? Jamie had it, but is it always needed when you have this diagnosis?
That's a good question. So there are some stages and some types of colorectal cancer that benefit from chemotherapy or radiation therapy or both before or after surgery, but surgery is still really the central element of curing this cancer.
And she did have chemotherapy after surgery. How is it determined if you need the chemotherapy or radiation after surgery?
Right, so that's based upon the pathologic stage. We remove the cancer, we obtain the appropriate margins of resection, and a pathologist tells us the stage of the cancer. In Jamie's case, she had lymph nodes that were involved with the cancer. That's why we knew she would benefit from chemotherapy.
Dr. Puleo, what are the symptoms of colorectal cancer?
So some of the symptoms may be abdominal pain, change in your bowel habits such as constipation or diarrhea that lasts more than several days, a change in the caliber of your stool where it could become narrower, or blood in the stool or rectal bleeding.
And are there some cases where the people have no symptoms at all?
Yes, in fact, most cases of colorectal cancer have no symptoms, and that is why screening is so important.
And we're certainly going to talk much more about screening later in the show because, as you mentioned, that is a very important part. Dr. Puleo, Dr. Stewart, thank you for being in here. Let's check in now with Amanda Peterson in the ABC 27 call center. Amanda?
Hey, Deborah. Yeah, the phones are busy. Check it out, the call center. These people are very busy right now answering all of our viewer questions. And if you have a question, you can call 717-346-3333 to get that question answered. One of our viewer questions we are going to get answered right now by colon and rectal surgeon Dr. Kevin McKenna. Thank you for being with us.
Our pleasure.
So this viewer says, I'm a 38-year-old female. I have a family history of colon cancer on my dad's side of the family. When should I get screened?
So we know there is a significantly increased risk in patients, relatives of patients who've had a diagnosis of colorectal cancer, particularly if they're first-degree relatives, in other words, immediate family. So the American Cancer Society recommendations basically are that colorectal cancer screening should start at age 40 rather than at age 50 for an average risk individual, or 10 years prior to the age that the relative was diagnosed. So if the relative was diagnosed at 45, the patient should have their initial colonoscopy at 35.
Okay, so 35 if that would be the 10-year limit, or 40 for the person who has it in their family history. All right, thank you for that information.
Welcome back. Earlier, we introduced you to a Lebanon County woman who was diagnosed with rectal cancer. It was genetic. Now, Jamie Ham wanted to know if she passed the gene onto her daughter, Jennifer.
King, you got a birthday coming up soon.
Yeah.
51-year-old Jamie Ham has a family history of colon cancer. Her grandfather had it, and so did her mother. Jamie started having colonoscopies in her early 30s.
They said every 5 years in the beginning when my mother was diagnosed, which that was the plan I was sticking to every 5 years.
The results of the colonoscopies were fine until 2013. Doctors diagnosed Jamie with rectal cancer, a cancer that was linked to Lynch syndrome.
Her tumor demonstrated under the microscope certain histological features that go along with a Lynch-related rectal cancer. And these genetic problems give those individuals an extraordinarily high risk, not just of colorectal cancer, but other types of cancers.
Jamie tested positive for Lynch syndrome. She needed to know if her daughter Jennifer was a carrier too.
So when I found out that I was positive, I had said something to her, and she's so much like me. You know, why would I have that done?
I didn't want to get it done because I didn't want to know. I didn't want to know and keep that in the back of my head because I worry about every little thing.
And I said it's very important that we need to stay ahead of this. And if I did pass the gene on to you, we need to know.
Jennifer finally agreed to be tested.
When I had the test, they just drew my blood, swabbed my mouth, and said, we'll have your results in a couple days.
And a couple of days later, she got the call, one she'll never forget.
And I remember sitting right here on my couch, and they said, your results came back very high positive for Lynch syndrome. Which I thought, maybe I should go have it done again, because there's no way. You know, I should just go have it retested. Maybe they mixed something up.
As a mother, I just felt so responsible. Because her life
she's young, she's in her 20s, you know, your life is just taking off. And it was like she hit a stop sign head on.
I wondered if I would die, but then I just kind of went every day and thought, but I'm healthy.
And, you know, that's heart-wrenching to see your 27-year-old daughter looking at you saying, am I gonna die? And I said, no, we're going to get a plan. We're gonna have a plan.
And a plan was put in place.
But it was very hard for the first couple weeks because it's just like, I felt responsible and she was scared to death.
I didn't understand how intense it was until I was diagnosed with it, and then I had doctor's appointments lining up. Then I realized this is something that I have to really take care of in my life.
So at 27 years old, Jennifer had her first colonoscopy.
Okay. Hey, Papa.
In between Jennifer's busy life as a horse trainer, she had a colonoscopy every year.
Lady Barrington to win it.
Everything was good until this past December.
I was fine. Nothing was wrong. I went in and I had it done. And when I had woken up, the doctor said, we did take a little polyp out. Looks fine, doesn't look bad. Call you with the results. And then they called me 2 days later and said, you need to come in immediately. It's about your biopsy. I went into the doctor, the same doctor that found the cancer in my mom, and he had said that inside of the polyp there was some cancer cells.
And again, there's her and I sitting in the car, just looking at each other like, here we go again.
I just felt like I was back in that whirlwind again, like, here we go again.
Dr. Stewart recommended another colonoscopy in 3 months.
The purpose of that colonoscopy is to make sure that there's no evidence that any part of that polyp that was removed has recurred.
Jamie had a colonoscopy earlier this month, and Dr. Stewart said there were no signs of polyps or cancer. With that news, Jennifer plans to move forward with her life, knowing her mom is standing by her side.
She was my strength. I probably couldn't have made it through my ordeal without her. And I'm going to be there now to help her, you know, with anything she needs.
She went through one of the worst cancers you can have and came out on top. She's been fine ever since. Her scans have been great. But so far so good, and if she can go through it the way she did and work and just keep going, then I'm gonna stay positive that I'm gonna get through it and it's all gonna be fine.
And as you can see, Jennifer is so positive and she is so determined to stay ahead of Lynch syndrome. Now, Dr. David Stewart is here along with genetics counselor Dr. Maria Baker. Thanks for being here. What is the next step for Jennifer?
Well, the good news is that Jennifer's most recent colonoscopy did not show any new polyps or cancers. So because of the diagnosis of Lynch syndrome, Jennifer will need colonoscopies every 1 to 2 years. That's different than for people without Lynch syndrome.
And so she's going to need even more than that. Dr. Maria Baker, that's why you can join us this evening. Talk to us about this Lynch syndrome diagnosis.
Sure. Lynch syndrome is the most common hereditary cause of colorectal cancer. But this condition also increases the risk for other types of cancers, such as gynecologic cancers involving the uterus and ovaries, as well as urinary tract cancers involving the kidneys and bladder and ureters, as well as other types of cancers. And given that it's hereditary, it has implications for close relatives, brothers, sisters, children, as well as more distant relatives like aunts and uncles and cousins.
And what percentage of colorectal cases are due to Lynch syndrome?
Approximately 3% of colon cancer is due to Lynch syndrome, Overall, we believe that 1 in 400 individuals carries Lynch syndrome, but unfortunately, most of those individuals aren't aware of it. There certainly are other colorectal cancer syndromes which account for another 2 to 3% of colon cancer being hereditary. Again, most of these individuals are not aware, so there's a big push initiative to screen individuals so that we can identify these families and change the course.
Yes, screening, and that's what we're going to be talking about next. Thank you both for being here with us.
This viewer had stage 3 colon cancer 4 years ago. They had surgery and chemo. So far, they're still cancer-free. What are the chances of that cancer returning?
So the greatest risk of recurrence in colorectal cancer is generally in the first 2 to 3 years after treatment. So with this patient at 4 years post-treatment, the chances are relatively low, and at 5 years we would consider the patient cured.
Excellent. And our last viewer question, this viewer has Crohn's disease, and they're wondering if they have an increased risk for colon cancer because of that.
If they have Crohn's colitis, then yes, just as patients with ulcerative colitis and other inflammatory bowel disease would. So their screening recommendations would be different than for the average risk individual.
Okay, so those people would definitely want to check with their physician about that. Thank you, Dr. McKenna, for being with us and answering questions tonight. And thank you also to the specialists in the call center. For now, we'll send things back to you, Deborah.
Thanks, Amanda. Now joining us is gastroenterologist Dr. Thomas McGarrity. Thanks for being here. When you first think about a colonoscopy, I mean, I'm sure you get all kinds of reactions. We're told prep is really the hardest part.
Right. So colonoscopy is a very effective tool to prevent colon cancer. But in order to get a good colonoscopy, you need a clean colon, and that takes a bowel prep, and there is some discomfort.
But the procedure itself is relatively simple.
Right. You'll have an intravenous line placed, you'll get medication by vein, it'll be painless, and you won't remember it.
And the age to have this?
So for most people, age 50 is when we start to screen for colorectal cancer.
Okay. Are there other ways to screen for colorectal cancer besides a colonoscopy?
Right. So colonoscopy is favored because if you don't have a family history, you don't have polyps, you come back in 10 years. Alternatively, you could check your stool for blood every year or do a sigmoidoscopy, a more limited exam every 5 years, and check your stool for blood every 3 years.
And are there ways to prevent colorectal cancer?
So a healthy lifestyle prevents colon cancer. So avoiding obesity, treating diabetes, being physically active, a healthy diet, all those things will decrease your risk.
And talk about the screening, because the screening really has played an important part as far as statistics are concerned.
Right, this is a good news story. So the number of people who die from colorectal cancer has progressively decreased over the last 2 decades. The number of people getting colon cancer has decreased over the last 2 decades.
So the thing is really to get out the word that screening is very important.
Right, the importance of the family doc to recommend screening and make sure screening gets done on everyone over the age of 50.
And what about future screenings?
So there's a couple things coming down the pike. We now have the ability to test for abnormal genes in the stool, so DNA tests in the stool. They're not ready for prime time as yet. There's virtual colonoscopy, there's wireless capsule endoscopy. Some of those things in the future may play a role as well.
And what are the risk factors for colon cancer?
So the number one risk factor is age. So that's why we start screening at age 50, and the rate of colon cancer goes up progressively with age. Certain ethnic groups, racial groups, African Americans are at greater risk for colon cancer.
And you're saying, so 50, when is the time that you usually see colon cancer in patients?
So the average age of diagnosis is around 65 years of age. Since we think most colon cancers come from these polyps, they start to be seen in the population in their 50s. So we start at age 50.
And if you do have a family history, how early is too early to start for a colonoscopy?
In most people who have what we call a first-degree relative, mom, dad, brother, or sister with colon cancer, we'll say start at age 40, and we may recommend colonoscopy every 5 years instead of every 10. But depending on how intense that family history of colon cancer is, it may be more often than that.
Okay, and what type of future things are we looking at as far as colorectal cancer?
Well, we think we're going to continue to have success. So as we screen more and more of the population, we're going to knock this cancer down and down and down.
Okay. Dr. McGarity, thank you for joining us this evening. And we also want to thank you, our viewers, for sharing your stories and sending in your questions. If you would like more information or if you would like to schedule an appointment, call 717-531-5164 or visit online at pennstatehershey.org/colorectal.